plastic, and of course the glass was the first material that people started using everywhere. Like when the invention of plastic came in, everybody everywhere, from toothbrush to baskets to phones to everything, plastic was there. So the concept of scleral lens goes, the credit goes to Da Vinci. In his drawings and everything, he has proposed that this can neutralize the irregularity of cornea. Keratoconus is not now; it is there since beginning. Only there was no instrumentation to measure. And now what happened, because of the LASIK surgery, refractive surgery, we are screening, full topography, and that is where you are finding out form first keratoconus or real keratoconus and what's happening. And then suddenly we think that, oh, the number is increased. But it is there. Right? So they used a glass lens and that neutralized. But you cannot wear glass because there is no oxygen. Cornea needs oxygen. 6 microliters per hour is corneal required. If you put any type of contact lens, it's going to have a issue with the breathing. Right? See, our whole human body works on oxygen and glucose. Right? These are the two things. Even your car petrol, only petrol will not work. It needs oxygen to burn. So same thing with cornea. Cornea is the only transparent structure in the body. So, and that's why it is more sensitive. So if you put a contact lens, if you have tried yourself or you have studied at least. So the breakthrough came in when Brian Holden's paper was published. He proved that 82 dK is the threshold material. Less than that, you will get a corneal edema if you sleep with the lenses. If in a wake situation, no problem, because the lens keeps on moving up and down. I'm talking about corneal RGB. So let us go back to scleral first. So the glass didn't work because oxygen could not pass through. Then the plastic came in. People can wear plastic lenses, but not more than 2 hours, 3 hours, because again the oxygen permeability is an issue. So they started putting channels and everything. So you get some. Then people realized that it is not going to work, and then the diameter came down, and the corneal plastic like PMMA contact lenses came in, and then as I said, the invention of plastic material continued, and they came up with the soft materials, and suddenly soft material became popular. Even today, most of the contact lenses won't, because they are comfortable, soft lenses. Then the toric lenses came in, so that is much comfortable. You can take care of the astigmatism. Coming back to sclerals, for few years, like maybe 50 years, there was nothing happening on the scleral lens front. Only ocularists used the PMMA scleral lenses. Like we take an impression, then paint it, put another PMMA layer, sandwich it so that it doesn't touch with the body, no reaction, and you're comfortable. But that was for the prosthetic reasons, not for vision. Of course, we could give some clear, pupil and everything, but you cannot wear for a longer time on a real healthy cornea. Then there is one optometrist called Don Ezekiel. He was in London that time. Now he's in Australia. Since many years he's in Australia. He's supposed to be, people call him father of scleral lenses. What happened is he used the same large diameter lenses, put a fenestrations. So the moment you put a fenestration, now there is a tear exchange happening through the hole, and you don't have to worry about oxygen anymore because you are at a normal pressure, normal tear exchange. So even today his son is in Devon. Don has stopped practicing, he's in Devon. His son continues the legacy, and there are so many other people in Australia who does fenestration. Don, I'm grateful that he is my guru, first guru. Then of course I studied in Moorfields Eye Hospital, London. Kane Pullam used to do the impression scleral, so I got a chance to learn from him. Then I went to Boston, Perry Rosenthal. He is the modern scleral lens guru. And many people don't know this, but everybody knows Bosch and Lomb, right? They are the pioneers kind of, but Perry Rosenthal is the person, he's a corneal surgeon, okay, and he was made a head of the department contact lenses. Now he's a surgeon and he has to do contact lenses, so he's a really intelligent guy. What he did is he continued there, but he realized PMMA will not take him anywhere because the limitation of oxygen. So he had two polymer scientists, started a company called Polymer Technology. It is there today also. So Polymer Technology is the parent company of Bausch & Lomb is the face, but they are the one who makes the buttons and everything. So first breakthrough was 15 DK oxygen permeable material they came in. Then of course 28 DK, 38 DK, about 85 DK, 84, 85 DK, then 100 DK, 120, 140, 160, and today 200 DK is the maximum FDA approved material available in the market. Of course, as you go more and more higher oxygen permeability, you have to add silicon. Pure silicon has 400 DK. Okay, but pure silicon cannot be used because it doesn't hold the shape. It is not machinable. So they add acrylic to it, and that's how. I'm just giving a basic this thing. Okay. So acrylic is non-oxygen permeable. Silicon is oxygen permeable. So you combine both. Of course, there are so many cellulose acetylbutyrate and other materials, but as of now, fluorosilicon acrylates are the standard, and that is how you get oxygen. So coming back to that 82 DK, so 84 DK you can wear and sleep, no problem. So it allows the same kind of oxygen what is required for the cornea. And from that invention or from that paper, all the orthokeratology, extended wear lenses. Orthokeratology is a closed lid situation. You put the lens in and go to sleep. Morning you remove and you see everything sharp and clear. So that can happen only because of the high DK materials availability. Now of course people use 100, 140, 160. Nowadays I use only 140 or 160, not less than that. So of course the oxygen transmissibility depends on the thickness of the lens material. So DK by T. So this is how the scleral lens looks like. You will see just now in your own hand, but this is a bigger lens. Okay, don't get scared. This is absolutely comfortable. It is much better than RGP lenses. I have stopped fitting RGP lenses since last 10 years. It's a absolute technology now. Of course, it's cheaper. That is how, when we started RGP lenses, old practitioners used to still say, no, PMMA lens is the best lens. They never know what, and they didn't want to keep up with the technology. RGP became the norm. Even today, RGP, corneal RGP is the norm. Now I am telling you, stop RGP. Go to scleral lenses. I don't like term called mini scleral lens. They are available everywhere because it's kind of easy to fit. But I would say at least use that than RGP lens. If you have seen some keratoconus patients followed up for a few years, and if you have fitted them with the RGP lens, you'll realize every 3 years they come back with a pain, photophobia, something going wrong. You see, okay, there is some, corneal issue. You ask them not to wear the lenses for maybe 2-3 days. Epithelium forms again. Again, you continue with the lenses, or you put them on a soft lens, piggyback, put a soft and put a RGP and continue. Second episode, now you start seeing the opacity. Previously there was opacity, but you couldn't see. It's a nebular opacity. Now there is a permanent opacity, and usually keratoconus central cone, if it is a central cone, that is in the visual axis, and then if there is the opacity forms in the central area, you have to go for a corneal transplant. So the whole idea is not to do corneal transplant, because corneal transplant it is a ticking bomb, I call it, because statistics shows that whatever corneal, say 100 corneal transplants, 50% of the corneal transplant will fail in first 1 year. Next 50% within 3 years. Next 50% within about 5 years. Max 10 years. Of course, I have patients with a clear cornea 20 years, 25 years, but that's very rare. It depends on the quality of cornea. What age was the patients when they retracted the cornea, all that stuff. But the idea is to delay the surgery, right? Of course, everybody knows keratoconus, corneal ectasia, thinning of the cornea in the center. If it is a peripheral thinning, it's called pellucid marginal degeneration. This is a regular keratoconus, nipple cone and all that. That terminology now nobody uses because it has no need now, because with the scleral lens what you are doing is you are vaulting over. Whatever is the problem, you are just putting under the carpet kind of stuff. Okay, so you don't need a keratometry. You need a keratometry topography for knowing what you are dealing with and to answer the question. Patient is going to ask you whether I have, it is regressed, it is improved, what happened. So you should have some baseline, and then you can compare. Hey, your cone was this much, your corneal thickness was this much, and now this has happened. So there are ways and means. Nowadays, CXL is the norm in the US. Yesterday, the cornel session, I was expecting somebody will talk about CXL. Of course, Dr. Bejan, he did spoke about it. But nowadays, the moment you get a keratoconus, they do a CXL. So that at least the progression stops. I don't believe in that. But I'm telling you, this is the norm in the US. The idea not to use the CXL at the first thing is first we try and give them options. There are a lot of surgical options, though I said that don't do any surgery, but it's a human life. Okay, if you talk to any keratoconus patient, he's so scared to death. People have suicidal tendencies. That they think that now I'm going to become slowly blind and I can't do anything, this, that. Lot of stories. Okay, they can really means if you don't have a vision, you're dependent on someone. Nobody wants to be dependent on someone, right? So you can fix that shape, you can fix the optical errors. There are so many things that you can do. Let us go back to the non-surgical thing first, and then when we get a chance, we'll talk about what are the surgical options for keratoconus patients. Keratoglobus is the whole. There are 16-24 sutures, and patient lands up in an irregular cornea. And to neutralize that, again you have to go for a whatever, RGP or soft or whatever. It never fits. Never fits. So patient has to ultimately, okay, patient, the corneas are wonderful, cornea is clear, everything fine, my surgery is good. Patients, I can't see, right? So they land up in your chair and you don't know what to do with it. Give 8 cylinder in this odd axis and all. So you can save this, and even if you get a patient with corneal transplant, you can still use a scleral. That's what I was talking about, the high cylinder. The Intax came in, like a corneal intrastromal ring. Intax is the company name. So basically, it was FDA approved for myopia. Can you believe? It was for myopia. Like there are inlays for presbyopia also. Nobody uses that because it's a surgical procedure. But the intrastromal ring was FDA approved for myopia correction. But now we have LASIK and other advanced technology who will do this. But they realize that it can change the shape. And most of the keratoconus patients have a lot of aberrations, irregularities. So if you put a ring, you can bring that shape to a little close to normal. And then you can do, I was talking about surgical procedures and all, they put ICL, they do surgical LASIK procedures and all. That's a permanent solution for those, because yes, patient is happy. It's a wow factor. You put the lens in and they start jumping around. Oh, you've given me new light, this. But after 4 or 5 years, they get okay, every day I have to clean the lens, I have to put it in, this, that, maybe midday fogging, infections, this, that. They want something permanent solution, and that is where you can offer the surgical procedures. Of course, you need a good corneal surgeon. It's a teamwork, so you can really help this patient. So, Intax patient again may need a scleral lens. May need, because many times it improves and they can get away with a spectacle. So this is a PMCD, peripheral marginal corneal degeneration. The thinning is not in the center, but it is down, and in Terence marginal degeneration, thinning is on the top. Different nomenclatures basically, but it's a thinning. Intax I just talked about. There was one big name, Dr. Hardiyal in India, and he used to do camps. Like in a day, he'll operate like 300 patients. Indoor. and I thank him because all those patients came to me now. It was really amazing. Means within on the table, patients start seeing sharp and clear. Okay, it was really master, the radial keratotomy. The surgery was invented in Russia, but they realized the problem and it stopped. But people who learned and went and saw it's amazing. Even he used to use Bharat blade. I think you don't know what is Bharat blade. It's a shaving blade. Okay. And it breaks into two, and then you put it into like a shaver. And of course nowadays diamond knife is used, but one blade for 6 cuts and throw it off. But the patients like jumps. Most of the patients were females because they want to get married. Nobody wants to show that I'm wearing glasses, this, that. The problem is, yes, their vision is good, everything fine. After the first delivery, the whole body changes, hormonal changes, everything, and the cornea becomes irregular because you weaken the cornea. And then they don't know what to do because now the cornea is irregular. You cannot put very difficult to put. Of course, you can put RGP lens, but you try putting RGP lens. Have anybody tried RGP lenses here on their own eye? Yes. You know how difficult it is. It's a of course, body will get used to it. You put the human body size and put it in hell, it will get used to it. That's how the body works. But now that you know that, hey, there are better options, why to put them under pain? Right? If you know dental, previously they used to just extract. Like even if you see the whole surgeries, they will hold tight everything and they're operating, right? Now you put anesthesia, you put so many things, make them comfortable, right? Even the first injection. See, I have my own eye hospital in Mumbai, and I get a lot of oculoplastic procedures like ptosis or these and that. Even that first injection, if you have to do, we put a topical anesthesia first, and then put a prick. You have to do only one prick, whether you put that topical or not. But keep the patient happy. That's how you can charge more. That's how people, you can keep them happy and they will come. Otherwise, there are other things. So, radial keratotomy can be really help. And there are so many patients even today. I think we are going to see one patient. So, they're still roaming around, and you can really make their life amazing. Traumatic injuries, of course, they have to do the surgical procedure to save the cornea, and afterwards they'll end up with this. But even with this type of corneal opacity, patient sees 6/6, 20/20. It's really amazing. Of course, if you put them on a contrast sensitivity, they may be, less, but they definitely improves granular dystrophies, high risk myopia. As I said, if you have more than -12, -15, it looks very odd. That's how you go for contact. But contact lens also has a limit, like how much you can make. So scleral lens, you can put anything. And if it is a corneal myopia, it gets nullified immediately. If it is actual myopia, of course, everything comes on the scleral lens. LASIK complications. There are so many new LASIK surgeons who are, it's a learning curve, right? So they do land up with some kind of a complications. Now this particular girl, I usually don't show the whole face, but very famous surgeon, I will not take the name, vision improved. But the moment the street lights are on, she's blind. Why? Because the target zone was smaller. So pupil gets enlarged and now everything is blurred. So she has to rush back before the street lights are on. So her life is only sunlight to sunset. Even before sunset, she has to make sure that she's at home or some safe place. So put the lens on. See, most of the patients, all of you, we are working during the day. Evening is for our family, right? While you are doing all these things, you spend time with your family, take them out for dinner, drive at night. All these patients, even before they tell you, if you start telling them you have a difficulty driving in the, oh, doctor, how do you know? See, these are the common things, right? So high order aberrations, irregularities, that is going to cause all this glare and blur, and even if you have a 6/6 vision, because of that glare, you cannot drive, you cannot see properly. So the scleral lens is used. Put a scleral lens, and the life is improved. This is another thing, Stevens-Johnson syndrome. They suffer. If you don't know about Stevens-Johnson syndrome, basically it's an allergic reaction to sulfa medicine, and it's a basically skin issue, but it has a sequelae in the eyes. The soft tissue gets irregular, becomes like a GPC kind of situation, and it keeps on rubbing. The eyelashes sometimes turns inside, keeps on rubbing. Every blink is a pain. Usually this type of patient comes in with a dark glasses, head down like this, a lot of pain. You put the lens, scleral lens in the eye, within 5 minutes, without they knowing, their head becomes straight. And in my practice, usually I put the lens in and say, okay, you go out, have a lunch and come back. Impossible. We can't walk out in the sun. Not possible at all. Okay, just try. They go out. By the time they come in, I want this lens. How much is this? Is my money. I'm taking this lens. Of course, you can't give them because you have to customize. But that kind of dramatic improvement, So, and within 3 to 5 years, the cornea becomes clear. Everything is, nice. Nobody knows that they ever had a Stevens-Johnson syndrome. So, this is a scleral lens. This is the anatomy. It sits on the sclera, walls over the cornea and the limbus. Okay, it should not touch on the limbus. Okay, there are so many people for the marketing reason, whatever this, it's a scleral lens, but it's a corneoscleral lens. It lands at 9 mm and then goes till 14.5, 15.1. It should not happen. You have to protect the limbal area. Limbal stem cells are more precious in the long term. So this is a kind of a terminology I want to go into. Corneal lenses, corneoscleral lenses, and scleral lenses. Now in scleral lenses there are two mini sclerals and full sclerals. Now how you decide what diameter you want on the lenses? So understand the anatomy of it. So these are the muscles which are inserted. So 5.5 mm is the closest, right? Then 7, 7.5 and 6.5. So your lens cannot go till the muscle insertion. So it has to be smaller. Now you have a corneal diameter, whatever, 11 mm, 10 mm. So you decide, you measure, you can actually measure. I'm talking about customization. Okay, there are so many. I told you can start practicing scleral lens from Monday. I still stick with that. But that is just a beginning. Right? You can drive a car, but that confidence, how to negotiate, all that thing will take time. So this is a basic thing. If you understand, then you will go into customization. I'm going to show you customization also. But if you have the basics clear, you can do whatever you want. So corneal diameter, till 2 mm of 1 mm this side, 1 mm this side. So 2 mm of limbus. Then at least you need 2 mm of scleral bearing. That means the lens is going to rest. When you see the Burj Khalifa, there is a half Burj Khalifa underneath. That's why it can hold it, right? So same thing. If you have more and more wall, you have to have a stronger and stronger base. So go larger, go bigger. If you go smaller, lens will decenter. It will, not give you a accurate thing, and then over a period of time you will see that ring, the scleral impression. So my preferred choice is 18 mm, but 16.5 is the smallest I will go, and then try and go as big as possible. If you have a diseased cornea like a Stevens-Johnson syndrome, ocular surface disorders, dry eye, chemical burns, anything where you have an ocular surface involved, it works as a band-aid. So try to cover the whole ocular surface and it will heal like anything. If it is an optical thing, then you can get away with a smaller diameter. But as I said, it will usually press on the limbal stem cell. Patients may land up in a glaucoma and other thing. There are no papers yet, what I'm saying. But believe me, I have been practicing since 2003, 2004, and a lot of complications. Of course, in medicine usually benefit versus risk, like that. So you're getting a very good benefit, so you let it go. But glaucoma is a serious thing. So there are fitting sets available. You select whatever fitting sets, whatever company you feel like, and then you can start fitting the lenses. So now we are going to talk about in the terms of vault or sag. Okay, you go back to your optometry school. So what is a sag is basically this is the lens, and the distance between that base to this is the height or sag height. If you steepen the lens, the sag is going to increase. If you flatten the lens, sag is going to decrease. Same way, if you increase the diameter of the lens, it is going to increase. So directly proportional to the diameter. So if you keep on increasing the diameter, sag will increase. If you reduce the diameter, it will decrease. So all that thing actually was applied for RGP lenses, but we never needed it because the sag was very minimal. So you never know. You have studied all that stuff. If you go back to your school and open the books, it is there. But here now it is more important. Now you forget all about RGP lenses. Now this is a different terminology. You have to think in the terms of sag now, because you are vaulting over. Vault and sag, I am using same term for the same thing. So you have to make sure your lens is not touching on the cornea. So you have to have at least 300 extra microns of sag. Okay, right now there are no instruments to measure exactly how much sag, and of course there are OCTs and all, so you can measure. But initially you just have to, I'll show you the tricks how to calculate, how to measure and make sure that you have enough clearance. So clearance is about 300, max we give 350 microns of clearance. Clearance means it should not touch on the cornea, the center part. Because cornea is irregular, some areas where it may be 150, 250, something like that, but we are concentrating on the center part because that is where the visual axis is. Second thing, you have to make sure that at the limbus, you should have at least 50 to 150 microns of clearance at the limbus also. And of course it lands over about, most of the companies will never tell you their parameters, but since I manufactured my own lenses, I went through a lot of difficulty. I cut my own lenses when nobody was there to help me. Only Don Ezekiel gave me the parameters and everything, but I had to make my own lenses. Making my own buttons. Okay, I spent a lot of time in educating myself. Now I can make 48 DK oxygen permeable material in my own lab. Now I don't make it, but if I need for my painted sclerals, another thing if you have seen my talk yesterday. So you have to make sure there is no touch on the cornea or on the limbus, and the lens sits on the sclera. So there are instruments available to measure nowadays. So this is a eaglet the eye profiler. So it measures the whole shape of the eye. Press a button, it goes to the lab. Lab will make a lens, send it to you. So the first lens will fit accurately. It may not have a correct optical. So if you put a scleral lens and tell the lab, hey, this base curve works good and this is the power. Or even if you put RGP lens and tell them this is the base curve and the power, they'll make the first lens which is almost 80-90% good fit. And then when you get the lens, you do the overcorrection. That's your lens, and it usually fits well. That's a Gaudi the eye profiler, which is still not available in the out of US, but this is the wonderful stuff where you can actually customize your own lenses. There itself you can see everything, and again it is connected with your whatever the lab you have. Sorry, I don't know the rules regulations about this country, so I'm telling you whatever we do in the US, you can fit from that. But if you have a irregular, see, cornea is irregular, you understand. So sclera is also irregular. Okay, it's mostly it is like a football shape, American football, or a egg. In one meridian it is different, other meridian it has a different shape. Patient has undergone maybe glaucoma surgery. There is a blade. There is some other issues going on the sclera. So that way you have to have a haptic molding, there are ping angulas, there are Parisian, there are so many things going on. Now that you are fitting, if you remember RGB fitting, you used to put fluorescein and see, measure this. Now this is much more area. 360 degree, you have to make sure that lens is fitting nicely and properly. So, and then you can alter the zone, alter anything, diameter, anything. So you put a note. In here you can change the wall, 4 meridians. You can have different walls, so that you can manage the limbal as well as the corneal clearance. And then you have the haptic. This is the limbal clearance, and you can change the haptic also. You can go up or down with this, and you can see what changes you are doing. Because sometimes numbers.
But as you go on the periphery, you see that especially at the pre-limbal area, wherein you see the black area, wherein there is a superficial touch happening. Of course, you can see it on the slit lamp in a bit detail, exactly how much of touch or clearance is there. So that's the second part, and then the last thing what you look at is the landing. So you look at the landing, and again you look down. You ask the patient to look down. You check the superior, then you look up, the inferior, the temporal, and the nasal area. So you just have to make sure that the landing is smooth on the cornea. It should be very well aligned. A minimal movement is expected. Usually, for insertion.
I don't want any movement.
No movement.
Yeah, forget about your soft lens fitting and RGB fitting. No, if there is a movement, you are definitely going to get midday fog.
There should not be movement.
There is a micro movement when he blinks, goes in and out.
That's
No
the ideal
vertical.
fitting. That's the ideal fitting.
And how to check out the bubble?
You can see that in the. As a practitioner, you can see with the.
If there is a touch, switch in the lens. You have fitting set, no? You take another lens. And if you exhaust, this is 16. Like in this case, suppose if you also ask the lab to, you can take a picture and send the lab, or you can tell them, hey, I'm getting a touch here. So it's a limbal area, I can notify. You saw my, if you have that
See,
software,
with the bubble, you will see the.
change yourself. And all these labs usually give you a warranted center. In the sense, in one, whatever money you pay them, till you get a perfect fit, they will keep on sending you another. So you send that lens back, you get another lens.
No, it cannot be the same.
If you have
Usually,
new, maybe
yeah,
third lens.
central is usually. Again, it depends on the type of the. Let's say if it is a keratoconus, central keratoconus, then probably you will try to maintain the clearance of around at least 200 microns at the center. And then as you go, you will get lesser, especially at the limbal area, you will be having lesser.
50 microns.
50, not 150. 50, 60, 70, that's the approximate microns we will have. So the landing is mostly happening. Because when you put the contact lens in, the clearance would be, you would target at least around 250 to 300 minimum. Yeah, and then you ask the patient to sit for at least 45 minutes to 1 hour. This is for the lens, because the lens is going to settle. Because it's a large lens, we will put in the lens, so the lens will settle down, but will get lesser and lesser. The suction effect will happen, and the clearance will get lesser in that period, first 1 hour. That's why you call the patient in again. Either you look at the fitting part. See, the first part we're not bothered about the vision. We are looking at the fitting part. Yeah, it's like a tailor made. You don't want to stitch the clothes. You go to the tailor, they take the measurements, and then they start cutting the clothes. The same thing what we're doing with the contact lenses, scleral lenses. We are looking at the geometry. We want to make sure we get the right fit first. Once we are happy with the physical part, then this last part is to get into the vision. Then we do the over refraction without the lenses to make the patient read. Whatever is the over refraction, and then we do the calculation. And then also we can do a lot of alterations, like Chandrashekhar mentioned, the alterations, like you have the tool, or even you can do it manually by yourself. But nowadays there are many contact lens companies, they have their online compensation tools, where which you can changing the sag, doing the alterations in the haptics. Even you want to do the front toric option, you have like say after over-refraction you found that the patient has astigmatism. Then you can even add the astigmatic correction. Yeah, I mean with the you have the tool. Yeah, you can use that.
That's why it came to us.
Yeah. Yeah, we can do that. Sorry, so when you will do the over-refraction, you know that let's say it's -1, 150, so whatever it is, you can add that one. So it's going to be fluorescent scleral. Again, you have these dots. There are also these micro engravings on the contact lenses. So when you're going to look at the position, and then you use the same rule of soft contact lens, LARS. Yeah. So we do that based on over-refraction and the dots, what we see in the slit lamp. Then we do that calculation and then we place them. Even the tools, they have this option. You put the values, you put your over-refraction values, then it will calculate. See, my logic is simple. Every contact lens will have their different thicknesses. Let's say the lens which I placed in, it has a 300 micron centimeter. So I will definitely look for minimum 300 to 350 microns clearance. So when you look at the slit lamp, you will look at the green band. It's like sandwich, right? You have the green band and then you have the lens thickness. So you compare these two. So your green band should be slightly more than the
Lens thickness is usually 300 micron. Cornea may be anything between 500 to 550 because it's a keratoconus, so it may vary. But 300 micron is what, compare that with your fluorescein. So it should not be more than 300. So you are in a safe zone and it should not be touching. So 200. Periphery, you just make sure that it is there is no touching, especially medical grade. Don't use any other regular dental materials, it will burn, okay? So use this specifically made silicone for that.
Any specific brand?
The company will give you whatever this thing. Impression tray, you have to make sure that his eye and your impression tray is not too big or too small. And this fenestrated trays are used for ocular prosthesis. It can be used for this. Usually my impression trays have no holes, but this also will work. We are not putting anesthesia. Do you have a soft lens? Okay. So sometimes you can put a soft lens on the top and then take the impression just to be on the safer side if it is a ocular surface also is involved. He is normal guy, so
put the soft lens first.
yeah, because that few microns you can adjust when you are doing a okay. So let us do this. So I have selected the left eye tray. It has a little notch here. We'll put it in the left eye. You have to be real quick. So I'm going to put this. Okay, I want to do down first. Usually the lower lid starts slipping down when you do, and you have to be real quick. So you can put a tape here, and sometimes so that it doesn't slip out, and you can pull it down. And it will really slip out. It's really so. Interested only in the center, look straight, keep looking straight, sir. Keep looking straight. See, there is no watering, no pain, nothing. So it's absolutely comfortable. It is not irritating.
For hurting also.
No, we are not put any lubricating drop, no anesthesia, nothing. It feels very great.
I'm doing the practice now, so I know.
Only initially.
Initially, yeah.
That's it. Then don't touch anything, let it settle. So it will get exact shape, even the blood vessel. It's
So
really
you have to move left and right after you.
Yeah.
For the first
Then
time.
leave. Keep asking, keep looking straight, don't move. You can give them a target or something to look at.
For how long?
40 seconds.
40 seconds.
So it depends on the temperature of the room. Okay. If it is hot, it will set faster. If it is cool, it will take time. So best is you touch and see. It is still not solid. Right? So you wait. So this is the ultimate. You don't have to worry everything perfect. No need to worry about which meridian to go and all. Then only you have to worry about the clearance.
Yes.
And first lens, even if there is any touch or anything, usually there is no touch. You can make that adjustment with the power. Second lens is your final lens. Of course, the lab will give you a free exchange and everything during that first 3 months of fitting. Initially, you may take 3 lenses or 4 lenses, but most of the time, if it is a regular keratoconus patient, second lens,
The final.
even first lens.
Even 3-4 lenses, they will give free of cost? Or?
Yeah, it is included in the cost. Only time, because they are not manufactured here, they are
It takes
from
time.
US.
Every time 3-4 lenses.
Yeah, beautiful.
You can include any dryness.
This is used for dryness.
So yesterday I tried, I'm putting some dryness.
What do you think? The
No,
lens,
this one.
silicone.
Silicone.
The silicone may be. Okay, so this is not. But that's okay. That's a temporary dryness. Okay, so don't worry. So now it is solid, right? So I'm going to just move the loading first. Okay, and listen for that click sound. Okay, and make sure that your ear is not this. Okay, then hold it and look down. Yeah, it will come out. Beautiful. Very nice. Right?
This is a softened that also come out of it.
Yes.
Okay.
See what happens is for first 5-10 minutes he'll feel little blurry, not irritation, blurry because
Use some lubricant.
yeah. So now we'll put the lubricant. Initially also I can put a lubricant, but then I'll get a wrong shape. Okay.
You need to put any
But what
Yeah,
about
now
the
I-
soft lens? If the lubricant
You can put a soft lens on the top just to protect the cornea. No need, but you can if you're
that is better than the lubricant.
definitely, because you know exactly which area. Only problem is sometimes when you do a silicone, the soft lens can move,
Slip.
and then again you have to do it.
Yeah.
How about
And the first
sensitive
lens that you
patients?
Huh?
get is to decide the prescription. Do a refraction.
I didn't get it. What?
When you take this and then you order the lens,
Uh-huh.
that's not with the prescription,
No,
right?
no.
You alter the prescription
No,
after the
I'll-
first
Okay, I'll
lens.
tell you. What happens is
The antibiotic we can do.
you can put antibiotic cover to be on a safer side.
Are you allowed to use antibiotics?
Now means
See, that is what I was coming to. Don't try to be do good for the patient.
You should start with lubricant.
We are always working with some ophthalmology or something, so you are allowed to do under
If
his
it's a
care.
hospital setting, yes.
Under his care. So coming to the ordering part, now you have taken impression. Try any RGP lens or mostly you have a scleral lens fitting. So put any scleral lens, make sure it is not touching, even this lens is fine, just do the overcorrection. Okay. Now you know the base curve of this lens. and the overcorrection. The base curve is important because if you change the base curve, the power is changed. Or if you put RGB lens, you know the base curve of that.